Welcome back to Navigating Cancer. I'm Dr. Joey Bennett with Wendy Hall, and again today we are joined by Dr. Kenneth Son. Dr. Kenneth Son is a urologist new to the area, Urology Institute of Central Florida. He's practicing in Marion County and in Citrus County at the corner of Line Avenue and Highland Boulevard. We'll be joined, we anticipate, May 1st by Dr. Tom Alderson, who will be here. So these two are going to team up and really are bringing a nice fresh air to the community of compassionate, concerned care for patients. So again, we're very glad to have you here in the community and also here tonight on the show.
Thank you.
First segment we talked about incontinence and urinary leakage and sometimes how people don't want to talk about that. Second segment we talked about erectile dysfunction, which again sometimes men are just embarrassed to talk about. In the last segment, I want us to touch base on prostate cancer and bladder cancer, and maybe start out with bladder cancer. It's pretty prevalent in our population of the retirement community, and tell me, kind of some of the signs that would concern someone.
It's funny because a lot of times you don't know. This is something that could sneak up on you, and many times a patient will come to my office from a referring physician and say, you know what, I was found to have a little blood in my urine, and this is what we call microscopic hematuria, where you don't know you have it. You can't see it with the naked eye. You can only see it under the microscope. Well, when that happens, there's two things that we want to do, and one is certainly to get an x-ray of the kidneys to make sure the blood isn't coming from the kidneys, and then we have to look into the bladder to make sure there's nothing bleeding in the bladder. And I think this is where we look into the bladder, and lo and behold, we find a bladder tumor. These usually are papillary type tumors, which means that when you look at them in the bladder, they look like a little tree kind of thing, just growing out of the lining of the bladder. And the biggest thing that I think we could contribute to these is smoking. And many times people will say, well, smoking is only, I'm putting the smoke in my lungs, it's not affecting anything else, but it is affecting. So the chemicals that are ingested and put into the bloodstream that are secreted or excreted by the kidneys and go into the lining of the bladder affect the lining of the bladder, and lo and behold, these bladder tumors arise.
It's one of the things we've discussed before on the show is the fact that when you look at the utilization of tobacco, it's the mouth, the throat, the esophagus, the stomach, the lungs, absolutely, but then you've got to get these 300 and something cancer-causing agents out of the body, and that's where the kidneys come in. And I mean, I think there's a slight increase maybe of kidney cancer, but the biggest problem is that when you're producing urine, that urine sits in the bladder until you go to the bathroom. And if you're a camel and you can get by with 2 or 3 times a day, you're literally sitting here with these toxins just irritating the lining of the bladder.
And secondhand smoke too, right? Or is that a myth?
I'm not convinced about secondhand smoke yet, and the only reason I'm not is that if you look at the statistics and you see what % of people have the type of cancer in the lung that comes from smoking, if you look at the secondhand smoke people, they don't show that kind of percentage. So I think that's still up in the air. I think that's, I think there may be a political theme to that. But indeed, smoking does cause bladder cancer.
And I think part of it's going to be how much secondhand smoke. I mean, if you're around a spouse or a significant other who smokes and you're literally confined with them a lot, that's not secondhand smoke, that's firsthand smoke. Talk about bladder cancer. Once you've done the cystoscopy and you see this, patients all the time are hearing the difference between an invasive bladder cancer and a non-invasive bladder.
Well, the next step, once we look in the bladder, we see that bladder cancer growing there, we want to resect it. We want to cut it out of the inside of the bladder using a scope. This is nothing that you would have an incision for. This is all done endoscopically. We remove the bladder cancer, and what we want to decide is this bladder cancer invading the muscle of the bladder? Did it go through the first layer of tissue? And that really gives us an idea of when the depth is our invasiveness. The other thing we want to look at is the aggressiveness of the cell. Excuse me, is it a very aggressive cell that we have to be worried about? And we have another type of aggressive cell in the bladder that we call carcinoma in situ, which is just a pathological name of a cell that is an aggressive type cell. So we want to know how aggressive it is and is it invasive or not. Once we decide that, then our treatment plans differ. If it's not invading and it's superficial, this is someone who could be treated with maybe some chemicals that we could just put into the bladder, as well as surveillance, watching them every 3 months for 2 years, and then every 6 months for 3 and whatnot.
And so literally you're injecting a chemical into the bladder, they keep it in for a certain period of time, and you get a nice coating, superficial type treatment for those types of tumors.
Right. Usually we put it in, we leave it in for 2 hours, and we have them go home and sort of get on a rotisserie and turn every 15 minutes so that the entire bladder is coated, and then they just void it out. So there's nothing internal. On the other hand, if it is invasive, then we have to decide how we're going to treat it, between surgery, or you could treat it with radiation and chemotherapy, which is very effective for it. And the thing is, the surgery is a major procedure. It is removing the entire bladder, and then you have to build a somewhat, we'd call a conduit, somewhere for the urine to come out, and this would be a piece of small bowel that would come out on the patient's side with a bag to collect the urine. It's a very big procedure.
And in men, you remove the prostate
along with
well,
when you do the cystectomy.
And I think that, you and I were talking earlier, historically the gold standard for treating an invasive bladder cancer has been removal of the bladder. Unfortunately, in our community, we have a lot of patients who are elderly and ill and have other medical problems, and so another alternative is the radiation therapy and the chemotherapy. But I think, that comes down to a good discussion between you and the oncologist and us working together as a team to decide what is the best treatment for each individual patient.
Absolutely. So everyone is different, and I think that we're seeing less and less people having the radical surgery, only because most people want to keep their bladder. They don't want to have a bag. And fortunately, we have the radiation and the chemotherapy now that's very effective for bladder cancer.
You're going to have him back.
I know. We're going to have him back for another show. We want to thank Dr. Kenneth Son for being with us. We hope you'll join us next week.